Okay. All right, everyone. Welcome back. I was wondering why everyone was so silent for this very interesting talk. And I was like, wow, no one has any opinions about anything. So I'm Meara. Nice to see everybody. I'm glad we have some people on here now. So this talk can be delivered to you. We're going to talk a little bit about sex today. And so I had asked everyone to type in the chat what your initial thoughts are. Oh my gosh, I'm mortified that somebody would talk about this, or oh my gosh, I'm inspired. I'm really looking forward to hearing what's going on. So if you have a second, you can do that. We're going to kind of rush through a little bit now just because we have a few extra minutes, but I'm excited to see what people write. So here we go. We're going to jump right in. And to start off, I want you to meet a few people. So here, this is Billy and Cora. This is Andrew and Mark. And this is Margaret. And these photographs of sexual expression were part of a campaign in 2021 in the UK. There were a collaboration between a well-known behavioral health group and photographer to spark this conversation and discussion about the appreciation of sexual expression in the elderly. When patients age, the common societal view is that sexual beings become asexual. And when they have health challenges or cognitive impairment, our kind of global society has generally avoided the need for sexual expression. And potentially we're denying a human right and a core activity of daily living. Yes, a core activity of daily living. These photographs of sexual expression were this is a complex and large issue with very little consensus, but important work is being done. We want to create an understanding. And today I want to focus on a piece of this issue that's particularly challenging, and that's sexual intimacy in dementia, and focusing in on what it looks like in long-term care settings, given that that's often where we are presented with some of the issues. So this article was published in the New York Times at the end of January of this year, the joys and challenges of sex after 70, so New York Magazine. And I think after, a couple of years of isolation due to the pandemic, there's really never been a better time to appreciate the value of human touch and the challenges of maintaining intimacy in a long-term care setting. So I have no financial disclosures. I'm just going to disclose that you may feel uncomfortable, you may tear up, you may feel inspired, you may feel, offended, hopefully not. But that's all part of this kind of a talk. So 3 key learning objectives for today. First of all, we're going to talk about the environment surrounding intimacy among dementia patients right now. We're going to look at some evaluate some proposed approaches to addressing sexual consent in long-term care settings. And then last, we're going to just touch on developing a strategy to manage challenging sexual behaviors, because that often is what causes a lot of distress for caregivers and staff. So let's pop into some of the numbers first. In 2018, Stacy Tesler-Lindow from the University of Chicago and her colleagues looked at data from the National Social Life, Health, and Aging Project. And they looked at a US household sample of adults born between 1920 and 1947. There were greater than 3,000 adults, the age 62 to 91 and mean age of 72. So pretty relevant to the population we care for in geriatrics. And the mean MoCA score was 22.7. And they found that greater than 50% of those aged 75 to 85 reported having sex 2 to 3 times per month. And of the partnered men and women, 59% of men and 51% of women were sexually active. In addition to that, 41% of those were aged 80 to 91, so in really later life years. And the majority of people reported that they were having sex less often than they would like to. And few men, only about 17%, and women, only about 1% of patients with dementia remembered talking with a doctor about sex. And so I do realize that if someone has cognitive impairment, they may forget that. But having practiced, I know this is something I need to start integrating more into my discussions. So what does this mean for nursing homes? This was a household group, but it means that people, maybe before they're transitioning were quite sexually active. And then we often think, okay, maybe they're, now they have no interest at all. And I think that's what I want you to take away from this. So, what is intimacy? I think a lot of people will jump straight to intercourse, that's sex. But there's a lot of other things that we think of with intimacy, and you can see some couples here expressing intimacy in different ways. I think one most powerful one is this bottom left during COVID, where they literally put up a plastic sheet so that two people could be, hug each other. And there have been some studies looking at this, and one found that Alzheimer's disease patients of both genders prefer non-intercourse intimate activities like kissing, hugging, cuddling, massaging. Over 70% of them initiated intimacy, and people with dementia responded really positively to spousal initiation. It was something that helped them and made them feel better. And then in a study in the late 90s, the sexual behavior of dementia patients was monitored by nurses over 14 weeks, and they defined it as 3 different types. So one was love and care, another was romance, and the last was eroticism. And they looked at staff perceptions of these different types of intimacy, and staff were really accepting of love and caring, very much an objection to eroticism, and had kind of mixed feelings about romantic behavior. So some of the benefits of sexual expression and intimacy: higher level of life satisfaction, quality of life, happiness of the caregivers. This is often, really important as people care for their loved ones. And then some positive physiologic effects like increased mobility. So those are important things to think about. And some of the barriers. So here, we have another couple from that same campaign that shared their story, and these are Chrissy and Roger. And they said there are barriers to having sex when you get older, but many of them revolve around health. Particularly if you've had surgery, you physically either cannot have sex or are too uncomfortable to have sex. Then the intimacy, the love that couples share often shines through. So some of the other barriers include lack of an available partner. If, looking back, the widows to widower ratio is 4 to 1, a lot more women, especially in long-term care settings. Lack of privacy or accommodations. So, shared rooms make it difficult to kind of have this privacy. Cultural, religious, and societal barriers. Some facilities are actually owned by certain religious groups that are against sexual expression. We can talk a little bit more about that later. Staff, provider, and family biases make it difficult, especially if you're in a long-term care type setting. Fear of stigma and litigation. There was a case back in 2015 in Iowa where a gentleman was accused of sexual assault of his wife with dementia when she was in a long-term care setting. He actually ended up winning the case, but I think that makes people nervous. And then physical limitations that we talked about, other comorbid conditions and medications. So as we kind of consider sexual expression, I would be very remiss if I didn't acknowledge the risks of sexual assault and abuse in the elderly. And so the most common context for sexual abuse is in nursing homes by other residents, and known in the literature as resident-to-resident sexual aggression. And there are also instances, though, within a trusting relationship where this may occur. And this is what makes it so tricky. I think I want to give a quick shout out to those in our division who are working tirelessly on this. I think our institution is doing some leading work here. And, we really walk a fine line between sexual freedom and safety, which is why this is such a complicated talk. And it's why it's important to have clear approaches to what sexual expression is, what is consent, especially in those with questionable capacity, and have solid staff training and to be in tune with signs and symptoms of sexual abuse. This talk isn't going to go much more into that, but we could talk all day about all of this. So now we're going to take a look at, kind of switch and look at how we determine consent in patients with cognitive impairment or dementia. And we're going to focus on this in the long-term care setting, as I mentioned, because that's where we're most often faced with these questions and decisions. And before we dive in, I want to take a step away from our clinical roles. And I came across this project where they asked kids to share what home means to me in the form of a drawing. And so I'm going to show you 4 of these drawings, and I want you to see if you see any common themes within these. So here's the first one. Here's the second one. The third one. And the last one. So I don't know if you saw what I saw, but what I saw is that the home isn't necessarily about the structure, it's about the love and the community. You see hearts in every single one of these, and these are small kids that can kind of appreciate what home means to them. And I think it's really, helpful for me as I take, look at this information to realize and remember that, long-term care facilities are a home for somebody. It's not the hospital, it's a home. And it's really important to think about that. And so, last week I met somebody who told me a story about a couple that she cared for in her CCRC, which is a continuing care retirement community. And the husband, he still lived on the independent side. He was very capable, but the wife had some medical conditions that made her need to be kind of in the skilled nursing area of the CCRC. And this woman was smiling as she told me about this couple because they really made an impact on her. She said she would run into the wife as she was going to visit her husband on the independent side, and she would be in the elevator in her wheelchair, and she would look up at her and say, I'm going to have sex. And I mean, you might feel pretty aghast by that, but she was very open. And at one point during the time they lived there, her husband couldn't actually get her back out of bed after they'd had sex. So the staff came and helped and assisted her back over to her side of the facility. And then as her cognition declined over time, they sort of like, is it still okay for us to have them, interacting? And so they brought in the 2 sons, and this provider told me she was mortified to meet the 2 sons because she knew one was a lawyer and the other one was in the military. And she was like, oh my gosh, this is not going to go well. I'm really worried to talk to them about them. And when she got in the room, they both looked at each other and laughed and like, that's just mom and dad. That's the way they've always been. And so, I think that story is just kind of a fun, one to hear about and to start thinking about when this is happening and what's going on. All right, so we'll dive into some more numbers, enough fluff. So thinking about sexual consent in a long-term care setting, there was an informal study of medical directors by the American Medical Directors Association a few years ago, and they found that 23% of medical directors were certain that their facility had a policy on intimacy and sexual behavior. And they had also found that 20% had a policy on addressing sexual consent. So very low numbers here. And I think so we know low numbers and this needs to be addressed, but what are some of these barriers? So one, like sexual values are so diverse. Views are different among cultures, patients, and staff. And so a director of nursing might be really concerned about some of the legal ramifications. Family may not be comfortable seeing a patient with another person. And attempts to define a normative approach that can be standardized across all places is probably not likely to occur. And so, we think about this kind of at an institutional level. And cognitive impairment, doesn't necessarily preclude a person from recognizing a desire for intimacy and pursuing a meaningful relationship. I think about capacity as a continuum. It may change and decline over time. And even though someone may not be able to make complex medical decisions, they may still be able to choose a partner or display nonverbal cues that tell them that they want to be intimate. So these are all things that make it just absolutely so challenging to address this, but all the more important. So again, some of the other things that come up, so we think of kind of finding a balance between law and regulation and the ethics, the intimacy needs of the residents of these facilities, the safety of other residents, concerns of other stakeholders like family and staff, and then the culture of the institution. So kind of briefly touching on law, there are no specific laws, common laws that regard sexuality in long-term care settings. So certain states will potentially have laws about, about sex in long-term care settings. They certainly have laws about, the age to consent. So, looking at the younger population. But in general, there aren't a lot of laws regarding this. And there are some regulations, saying we need to essentially that say we need to make these living environments as restricted, as the least restrictive as possible. Again, this is someone's home. So remembering that, that as we go through. And so the American Bar Association and American Psychological Association published a handbook on capacity in older adults, and there's a section assigned specifically to sexual consent. And, they essentially said the most widely accepted criteria when looking at consent for sexual relations are these three things. So one, knowledge of relevant information, including the risks and benefits. Two, understanding or rational reasoning that reveals a decision that's consistent with the individual's values. And three, voluntariness, a stated choice without coercion. So those are some kind of guiding principles. And as we're on this law section, I also want to make point here about who can make a decision about sexual consent. Unless a court specifically denotes that a guardian has, the right to rule over or make decisions on sexual consent, they actually don't have the legal right to do that. And in addition, MDPOAs also cannot consent for sexual interaction or intimacy, unless somebody is at risk and being harmed. So I think those are important to think about as we think about involving people in the discussion, especially in a long-term care setting. So we also think about the ethics behind this, our common principles of beneficence, non-maleficence, justice, and autonomy. So some things, we might think about for beneficence, we're trying to promote satisfaction and well-being, trying to, respect the human right to govern one's body. From non-maleficence, we want to protect the patient's reputation. So if a patient doesn't know what they're doing and they're going out and doing inappropriate sexual behaviors that we think of as society as inappropriate, that's something we have to think about. You're protecting family and spouse from stress. So if someone's in a facility and they, have a new partner and then their family shows up, that can be an issue. And we want to protect others from unwanted aggression, especially resident-to-resident aggression. And then justice, we think maybe about treating residents fairly and equitably, and autonomy, thinking about the right to be informed and evaluate the risks and the benefits of a decision. So those are kind of some of the things to think about from an ethical standpoint. So then how do we apply this in real life? Because those are some sort of theoretical things we think about. So in general, you're going to identify a situation in which consent is not clear. So if consent is clear, then if it's inappropriate, you might redirect and move it somewhere else. But if consent is clear, that is something that we need to respect. If it's not clear, we would stop the action or use a non-pharmacologic approach, which we'll talk a little bit about later, to kind of intervene in the moment at that time. And then, attempt to assess capacity. And if it's not a clear-cut case, you're going to discuss with an interdisciplinary team. And so the interdisciplinary team approach is pretty standard across different settings for how to address this. And I think mostly is because you're getting multiple, perspectives, and that's really helpful to addressing this issue. So one interdisciplinary approach that is being proposed by the American Medical Directors Association is this. So I'm going to walk you through the different steps. So they would go through as the IDT and look at this question. Is the resident experiencing unwanted sexual advances? Is the resident able to say no or resist unwanted interaction? Is the resident willing to engage? And then does the resident have capacity based on those things? And so if in these, 4 steps, they determine, and then the capacity, is determined by, can he or she correctly identify the other person? So if you don't, if someone is mistaking someone else for their spouse, that is considered, generally considered that they don't really have capacity. Do they understand the risks and the potential impact on others and on their reputation? So those are the things that are considered. So if the resident is deemed to not have capacity, they then don't stop there. They actually move forward to another 2 steps. So the next step would be to say, does the resident benefit from this, or is this harmful to the resident? And I think that's, a key point here is, different types of intimacy may not be as harmful as others. So intercourse versus holding hands are seen as 2 very different things. And, do we think that this is harmful? And it's, maybe the resident's actually doing quite well because of that interaction. And then will someone else be heard? So that kind of where, again, the family piece comes in. If someone has a spouse that lives outside of the facility and they have a new partner, will they be heard? You may have heard about Sandra Day O'Connor's husband had Alzheimer's disease and was in a facility, and he developed a relationship with someone else while he was there. And her perspective on it was, I'm just so glad that he has someone to be with and to make him happy. And she was okay with that decision, but some others may not be. And so I think that's something to think about. Okay, so that's one proposal. And then here are a couple other examples of how this is being done in the community. So this is the Hebrew House in Riverdale in New York. And it has been known to be pretty progressive and kind of liberal with their sexual culture and about sexual expression. So in the late 90s, they started talking a lot about this and actually developed a policy for sexual expression that was first issued in 2000. And they actually have this, literally, if you go to their website, you can click on it, pull it up and look at it, because they want to be, they're that open about their policy. And so kind of going through some of the pieces of it, I want you to see different components that are included here. So here's their policy. And I know it's a lot, but I think it's important to kind of think through how people are thinking of this. So, they talk a little bit about the importance and, what they define as sexual expression, that the residents, have the right to seek it out, and they can have access to things that they need to sexually express themselves, and also have a right to a private space. And then down here that I have highlighted, this is this part on those who are cognitively impaired. And, they also take the interdisciplinary care team approach, and they've also been really involved in the AMDA white paper regarding this. But that will determine, the interdisciplinary care team will determine the relative benefit or potential harm regarding sexual expression, and then they'll develop a care plan involving the resident's legal surrogate. So I think that's interesting, the involvement of the legal surrogate, and thinking about what things still need to be private to protect the confidentiality of the resident if we think that they, don't have capacity versus what needs to be shared. And that's probably a whole nother talk. So, and then also that they really focus here on the staff's responsibility to uphold and facilitate resident sexual expression, and that there needs to be, culturally sensitive staff training and resources so that the staff feel enabled to do this. Again, here's kind of their purpose. They do involve a legal surrogate in their policy, and then they protect the right to privacy and kind of maintain this right. And then here they have kind of their steps by step, what they do if somebody with cognitive impairment or impaired capacity is being considered. So the interdisciplinary team will investigate and make a judgment regarding the relative benefits and harm with the sexual expression. And if the expression does not appear consensual, obviously there needs to be an immediate intervention until there can be a care plan developed. And they inform and involve the legal surrogate, and then they develop a care plan that's then updated on a quarterly basis. So you can see here they included some timing too, and then also if there's a significant change. So that's one policy that's been done. And then the Colorado Safe Vets Home was willing to share a little bit about what they do too. They also have a policy that I think is great and a great start. They kind of have this step-by-step that they go through. So first, in general, as as staff working in a facility, they will document observation of residents that are engaging in intimacy or sexual activity, and they will notice the director of nursing and or social work of what's going on, so that everyone's kind of aware of the environment. And while that happens, I think the other thing is also maintaining some privacy. So I had someone tell me a story about where a CNA walked in on someone and then told the whole facility about the experience, and the person was very embarrassed, the resident was, and was really sad that his privacy had been violated like that. So within limits, they need to share this information. And then staff is obviously going to intermediately intervene and separate residents if any resident appears uncomfortable or distressed, and then report immediately to the supervisor. And in their policy, they say, they'll then go follow the facility abuse policy. So again, having that specifically set out here of how we deal with the situations where we don't think this is safe. The staff will then will also redirect people if they're engaging in intimacy in public areas. They will notify the interdisciplinary team, and then they complete an intimacy consent assessment for those who they don't think can consent initially. And so on the left-hand side here, these are just some of the qualities that they look for. So they kind of look at interaction patterns, they look at the body language, and then kind of look at, find out, do they have the opportunity for choice? So can they, leave an undesirable situation? Can they verbally or non-verbally let someone know that they need help? So those are kind of important pieces of theirs. And then they determine green means, kind of go, they can make known when they want to engage, and we think they do have capacity. And then red is no, they don't have the capacity and they're at risk for sexual abuse, and then they need to come up with a plan for how to deal with that. And other considerations with these policies, we've got to engage in staff development, share the policy, make sure that staff is really knows what the policy is and knows they need to follow that. The education of residents and families. So it's proposed to provide this to them during the admission process. So everyone knows, how does this facility address this, especially if they have certain cultural beliefs that go against how that's addressed. I think it's important to put in reevaluation intervals, because obviously capacity is something that is changing, and so cognitive impairment progresses, important to reassess. And then have clear algorithms, like I mentioned, for sexual abuse and sexual assault, and a clear plan for accommodating those who do have capacity. So do they need a private room? How are we going to actually accommodate those who have the capacity to make these decisions? Okay, take a deep breath, and then we'll move on to the last part of the talk. Okay, good. We still have time to talk about developing a strategy to manage challenging sexual behaviors. So as we go through this one, if you have a story about a challenging situation and you want to share it with everyone, you can type that in the chat. And even if you have a good strategy for what you did, please feel free to share, because this is all about sharing, because there's not a lot of information about it. So here's the maze I think of when I think about how to address challenging sexual behaviors. And before we dive into that, I think just mentioning that most people with dementia actually have sexual apathy or hyposexuality. So this is a small subset that have these kind of challenging sexual behaviors. But the reason why we want to talk about it is because it is extremely difficult for people to manage, and it's tough. So and then the maze here also is it's difficult to manage, and we just don't have a lot of information on what's the one thing I can do to make this better. And often we need it right away, or you want it right away, and it's not going to happen. So anyway, so challenging sexual behaviors. I intentionally have titled this challenging sexual behaviors. In the literature, you'll hear sexual disinhibition, you'll hear hypersexuality, and I'm pretty intentional here because we need to consider that it may not actually be hypersexuality, but a sign of distress or pain or discomfort or boredom or all those things. Or maybe someone that has normal sexual needs, but just doesn't understand the social context. So that's kind of why I put that here, because it encompasses all these things. So types of challenging sexual behaviors, you'll hear about sex talk, so that's suggestive language. You'll hear about sexual acts, so people who are masturbating in public locations, fondling other people's body parts, and intercourse itself. And then there's implied sexual acts. So for example, there have been instances where a resident will ask for kind of excessive genital care from nursing staff, and that's kind of an implied sex act. Again, they're fairly rare or they're underreported. So the literature is all over the place, between 4 to 5% to 25% of patients with dementia having these challenging sexual behaviors. And they're more common in skilled nursing facility settings. And I think, again, is it really that they're more common in skilled nursing facility settings, or is it because we don't have good reporting mechanisms for this? And I think I would probably argue the latter, but I don't have anything to actually support that. And then men are more likely to be aggressive, and women more likely to be verbal in their challenging sexual behaviors. And there's also an association with severity and type of dementia. So what we found, again, limited research, more common in frontotemporal dementia, and Huntington's disease is often seen as well. And then, I think another thing here is that a study of 300 nursing homes found that in 17 to 25% of residents, they had unpleasant experiences from the behavior of other residents. So it's a very significant source of distress for family members, staff, and other residents in long-term care facilities. And it often ends up being what kind of makes caregivers break down and admit someone to a long-term care facility. So thinking about some of the causes of challenging sexual behaviors. So it can be very multifactorial. We think about, neuroanatomical structures. So if somebody is affected more in the frontal and temporal lobes, the striatum and the hypothalamus, see, frontal loss of inhibitory mechanisms and temporal loss of emotional and intellectual interpretation. And so if people have those structures more often affected, then we may see this more. Medications and substances. So dopamine agonists and levodopa can often cause these behaviors. Benzodiazepines, other substances like alcohol can also contribute. Psychologic things, so loss of self-esteem or self-image, lack of physical closeness and boredom, those are all things. And then also like an underlying prior mental health disorder that is affecting this. Environmental things, so kind of lack of privacy and restrictive attitudes in the environment. And then kind of unmet needs. So maybe it's normal sexual needs, but misinterpretation of the social context. Maybe it's pain or discomfort, things like that are contributing. So thinking about all these things as we address this issue. And then talking about management a little bit. So step one is to do an evaluation. Obviously, you always go to the patient's bedside and do the evaluation. So doing a history, a physical exam, looking at the acuity of the behavior. So is this delirium or an infection that we're missing, or is this something that happens all the time? Look at, their prior sexual history. If you can get information on that, do a medication review. Talking with family, again, kind of respecting certain privacy measures, but also asking family to get a little bit more history. And then the next step after you do that evaluation, if you're still having issues, is to do non-pharmacologic intervention. And that's kind of our first line, and then go on to pharmacologic. And so our goal is to decrease whatever behavior this is to a manageable level, but not necessarily eradicate it. And I think it's important to set that standard for everyone, knowing that it's probably not going to go away entirely. So looking at some non-pharmacologic approaches, again, this is the first line approach. And even though it's a little bit often easier to grab for medication, again, that immediate fix, and it's frustrating for staff to do the non-pharmacologic approach, we still think it's better for residents. So similar to evaluating sexual consent, we need to involve the interdisciplinary team. There was a study in 2007 in Australia that looked at either usual care or a tailored plan by the interdisciplinary team. And they found that the control patients had twice as many psychotropic medication changes throughout that time period, and 25% spent time in an inpatient unit where only, and And in the intervention group, only one patient was hospitalized. And 77% of the changes in the intervention group were psychosocial. And they had a 44% decrease in the difficult behaviors. So the IDT was important in that study. Different approaches to take. So some are distraction. So offering another activity to do and just kind of moving things along. Compassionate deception is one. This is a kind way of saying that we're lying to the patient or resident and telling them that something can't happen for a different reason. Clothing. So some have looked at, putting on clothing that opens at the back. So if somebody is, doing a lot of public exhibition, this is helpful for those patients sometimes. Again, there's some ethical concerns here, just about, restricting people. Increasing hands-on activity and sensory stimulation. And then increasing affection for that person, having pets, family, other inanimate objects like a doll or stuffed animal, and then, helping to boost their self-esteem. And then the last thing is, supportive psychotherapy. And that's for, caregivers and family members to help them understand why their loved one is acting this way, because behavioral therapy itself is unlikely to help a patient due to their cognitive impairment. So they can't actually integrate, these new strategies because of their cognitive impairment, but family members and caregivers can learn to understand and learn to manage this. So it's another key component of these non-pharmacologic approaches. Yes, and the last thing I think is most important, creativity and patience. So being really creative about how this is approached, individualized for different people, and then being quite patient as this happens, because again, it's not going to be a one and done. And here are just some photos, because I think it's helpful to just see and kind of uplifting to see these of things that we can do that are non-pharmacologic. So we've got the pet therapy. On the bottom left, we have a sensory corner, or Dr. Beck talked about the snozzling room a while ago in one of our journal clubs. So if you haven't heard of that, you can look that up. It's sort of a sensory bin. Down in the bottom middle here, we have this inanimate cat that purrs and moves around a little bit. Baby dolls, there's actually a recent study about doll therapy, not specifically looking at sexual expression, but just in general for behaviors. And then at the top right, we have music therapy, which can be quite powerful. And thinking about these, like, again, there aren't any really great studies for any of this. It's more experiential, and the studies that have been done don't typically look specifically at sexual acts, but they do look at kind of overall behavior, agitation. And so that's kind of what we're drawing this from. Okay, and then if we can't manage things with these non-pharmacologic approaches, we can, think about pharmacologic intervention. So the first step here is, there is to remember there are no randomized controlled trials that are establishing any safety and efficacy for these pharmacologic agents, and there's extremely little data in women. So take what you will from this, but again, just kind of knowing that. Step number one, though, before we even bring out a medication, is to adjust any exacerbating medications. So we know that patients often on levodopa with Parkinson's disease will have kind of a more inappropriate sexual behavior, and dose reduction, if possible, can potentially help with this. So thinking about those things. And then our first line is going to be an SSRI. There's really, again, no good studies on this, but we take from other studies and take from other healthy subjects too, and look at how it's affect their sexual drive. And so an SSRI is our first. And then in some of these, a bunch of review articles, they kind of prioritize what they would do next. So next they'd say a TCA, then mirtazapine, then trazodone. Again, I feel like it's a little bit of someone's opinion and experience more than actually having good data behind that. And then other things that have been looked at, anti-androgens, estrogens, or luteinizing hormone releasing hormones have also been looked at. There have been other case studies looking at like anticonvulsants, carbamazepine, gabapentin, H2 receptor agonists, spironolactone, ketoconazole, ribostigmine. All of these things have kind of been looked at in very limited case studies. And then, but I think there is a general agreement that we should avoid benzodiazepines and antipsychotics for addressing this. And there are some, kind of ethical concerns here too about using estrogens and antiandrogens. Is this chemical castration? People will talk about, and so just thinking about that as you, decide what to do with the patient. All right, so good. Okay, we still have some time for questions. So those are our 3 steps, I think, learning objectives for today. So number 1, just kind of get an understanding of, what is intimacy among these patients. 2, we looked at a couple of proposed approaches to determining sexual consent. I provided 2, that, a lot of places out there don't have this. So if anyone's interested in developing a policy for a facility, we could do that. And then 3, we looked at, what can we do to manage challenging sexual behaviors, especially in these long-term care settings, and knowing that we should start first by doing an evaluation involving our interdisciplinary team, doing non-pharmacologic approaches, and then going to meds if we can't control it any other way. So here are a couple of references. And at this point, I want to take some questions because I think that ideally this would have been done in an in-person setting anyway, because we can talk a lot more about things, but would love to hear some more. I'm going to look here just at the chat and see if anyone had a story. It looks like someone had a story here at the end. So let's see. Jolene Sussman mentioned that she'd found just asking more solves the problem. So usually asking more when a wife says, he's masturbating all the time, should I keep my grandkids away? Then when asking more to find his masturbating is within normal limits, just he's not good at hiding it from his wife. There's no danger to the kids. So that's super, super. Thanks so much, Jolene. Did anyone have any other questions? Things they want to bring up? I'll give you a few seconds to type in there. I think, I went to this AMDA conference last week and there were a couple people talking about this and so it was really fun to see what's been going around across the nation. But everyone has a story about, something that sticks out as, maybe being an inappropriate sexual behavior or a challenging story about this. And so I think just taking away from today that if you talk about this is important. Yeah, so Sarah Teets asks, do you think we should talk about sexual consent during a dementia diagnosis visit? Should we do counseling on this during the first diagnosis? Sarah, I think that's a great question. And obviously this is going to be my opinion. So if others have it, you can type it in the chat too. But I think, I'm not sure if I would talk about sexual consent initially, but first at least get an idea about what does intimacy mean to them? And, are they even sexually active? What does that mean to them first? And then maybe we talk about it at the next visit. I think those initial diagnoses are filled with diagnostic visits are filled with so much information that maybe that's not the very first time we should talk about it. But I do think at some point it should be brought up. And gosh, I've been terrible at talking about, sexual activity with my patients. I noticed like this week I was so intentional to ask and just try to, figure out how do you do that in a very comfortable way. And so hopefully, we can start doing this more. If anyone does this on a regular basis and does it well, we'd love to hear how you do it. Okay, I don't see any other questions. I'll just leave you with this. Again, at this conference, someone asked, all these people are working in long-term care settings, and someone asked, how many of you have ever said you wouldn't want to live in a nursing facility? And pretty much everybody raised their hand. And so I think going back to that picture, those pictures of the house and remembering that this is someone home and how can we make this feel more home-like, I think the last couple of years have made it extremely hard to do that. And so hopefully moving forward, we can kind of get back to where we were before. Thomas, great question. How do we get condoms and barrier contraceptives for patients in long-term care? Great question, Thomas. I don't think that there is any standardized way that this happens, but sometimes staff will actually go out and buy them for people. But we need to do that. That's a great thing. Maybe we can work on something like that. Coming up with an approach to making sure that that is available, and maybe available in a way that they don't have to ask staff. Because I think that's another thing is like, do you really want to go ask your nurse for a condom? Like, you're a kid again. Yeah, so Sarah Beck says you can order them from the VA, which is great. But yeah, I don't know that this has been really addressed. So that's a great question, Thomas. And some facilities will even have talked about, like, they'll go out and buy pornographic magazines for their patients. So it's very interesting, and it's very facility dependent. But having that culture and figuring out what your culture is going to be is really important. All right, Samantha Farrow says, any way we can normalize sexuality with our patients is important. I approach this as a normal aspect of human experiences and expression. Thank you so much, Samantha. Yeah, how to normalize it is very important. Okay, well, if anyone has other questions or you're interested in this, I now have a new interest in this, so please feel free to email if you are, and we can talk more on it.
Thank you so much, Meara. This was a great presentation. Lots of interest, and kudos to you for taking on a difficult but really, really important topic. So thank you so much. And thanks everyone for attending.